Hey everyone, and welcome to the Flatlining podcast from Fulcrum Strategies. I'm Matthew Handley, and with me is our president and CEO, Ron Howrigon. Ron, how are you, sir?
I am good, thank you.
Today we are talking about something that providers need to worry about and seniors need to worry about, and that is Medicare Advantage. Open enrollment period is approaching, as it does every year, and I'm already starting to see some of those ads on TV, and there's several news items about different promotional partnerships that have been happening with Medicare Advantage. So we're going to talk about that today. We're going to talk about who it's for. Does it actually save money? You know, what's the deal with some of these promotional partnerships, and should providers be caring about Medicare Advantage as some hospitals continue to go non-par? So Ron, let's start with the basics here of Medicare Advantage. You have traditional Medicare, which is your red, white, and blue card issued by the federal government. How is Medicare Advantage different, and what was its purpose made for?
So Medicare's Advantage is different, and its whole purpose was designed to cover those things that your red, white, and blue card don't cover. You know, the traditional Medicare has a coinsurance where the person pays a percentage of the bill, a deductible. And on the pharmacy benefit has what everybody knows is the donut hole, a part where, you know, Medicare doesn't pay for drugs. So the Medicare Advantage plan, and when they originally started, they were called supplemental plans, were designed where they would cover those things. So you wouldn't have to worry about coinsurance. You wouldn't have to worry about deductible. You wouldn't have to worry about the donut hole. You could pay some fairly nominal premium and get all of that covered. So it was really kind of a good and interesting idea to help seniors who many are on some fixed income, et cetera, not have to worry about paying a deductible if they have surgery, or not having to worry about paying coinsurance for certain things. So that's really what it was designed around, doing what it does today.
So those of us that are younger, like me, who've never had to give any thought to, you know, our red, white, and blue card, the traditional Medicare card, you know, so it sounds like what you're saying, traditional Medicare has got some sort of deductible that you'd have to pay a copay, and it's a little bit different from Medicare Advantage.
Yeah. There's Medicare Advantage provides the seniors who have them much more benefits, you know, less out-of-pocket expense, significantly better benefits, and that's why it's been so, you know, successful.
So if it's less out-of-pocket expense for the senior that has a Medicare Advantage card, and it provides more benefits, in my head, I'm thinking that must cost more for the insurers that are providing these. So does it save the federal government money, and how?
Well, there's a big question about whether it saves the federal government money, and that's probably something that is extremely difficult to calculate.
Sure.
Because what you would have to do is say, well, if this person didn't have Medicare Advantage, what would they have cost? What would their health status be, et cetera? So I'm not saying it doesn't. It's saying it's probably very difficult to calculate. Some people think it saves money, and some people don't. What the insurance companies say is that some of the policies that they do, care management and, you know, incentivizing certain things from primary care, et cetera, lower the overall cost and save the federal government money. And I don't have any data that suggests that they're wrong,
right?
But you really can't point to something very definitive that says that they're right.
Yeah. I've seen ads in recent years, and I'm sure you have as well, that for many seniors, Medicare Advantage is Medicare, and that is demonstrated by the total number of enrollees. Next year, we're expecting to see 33.8 million enrollees in Medicare Advantage plans. That's more than half of the population that is eligible for traditional Medicare. And it's widely popular with seniors. 95% of members are satisfied with the quality of their health care on a Medicare Advantage plan. But you have a lot of criticism from folks like Wendell Potter. And of course, Wendell Potter, you know, we've talked about him before, is kind of big into the universal health care, single payer health care, Medicare for all. So why would folks like him or Senator Sanders, I don't know if he's spoken on Medicare Advantage, but why would they be critical of Medicare Advantage when it seems like most of the people that are on it, the vast majority of people that are on it, like it, and it's now more than half of Medicare patients?
Yeah, so folks like Wendell are not critical of Medicare Advantage because of what happens to the patient. They understand that these people get greater benefits, that they're generally very happy with it. A lot of these plans have very broad networks. And so from the consumer perspective, that's not what their issue is. Their issue is they believe, and again, I don't think that the insurance companies could prove them wrong, that these insurance companies are making exorbitant profits, that they have sort of tricked the government into paying them significantly more money than they should. And that's his issue, is that why should private insurance companies, for-profit insurance companies, make all this profit on seniors? Couldn't we have done this, meaning get rid of the co-insurance and deductible without also lining the pockets? And this would be the kind of language that Wanda would use of for-profit insurance executives that make significant profits. Now, I will tell you that there is one piece of data that tends to suggest that there is additional profits in the Medicare plan. Mm-hmm. One of the things that, for example, the Kaiser Foundation tracks is what they call the gross margin, which is per enrollee. If you take the premiums that an insurance company collects and subtract out all the claims, how much money is left over per enrollee? Now, that's not profit, because out of that money, they've got to pay their administrative cost and claims cost, all that stuff. But it's sort of like, well, this is what you've got left over to pay all of your administrative costs, and then anything left over that is profit. So if you look at the individual market, the group market, which is the employer group market, and the managed Medicaid market, all three of those segments have a gross margin of about $700 per employee or per enrollee per year. Okay. Mm-hmm. And that makes sense that, each of those markets. Medicare Advantage is $1,700 per enrollee per year. Mm-hmm. So one of their arguments that gets made is, wait a minute. If they're profitable in managed Medicaid group and individual at $700 per enrollee per year, then they must be obscenely profitable in the Medicare Advantage at $1,700 per year per enrollee. And I think there's probably some logic to that. If it were not a profitable line of business for the insurance companies, nobody would be doing it.
Right.
So that's Wendell's thing, is why are we spending taxpayer dollars to provide profits to these for-profit insurance companies?
So we already talked about that it benefits seniors, particularly low cost or low income seniors that are on a fixed income. Is there anyone you think that who has a Medicare Advantage plan who really doesn't need it? In a sense, who is it not benefiting by that person having it?
Well, I think there's probably two different scenarios where it isn't benefiting. One is a scenario where a senior buys a plan and maybe doesn't look into the details of it, and their, the physician that they use for their rheumatoid arthritis or for their neurologic needs or whatever is not in that network.
Yeah. And
so they could find themselves having to break a physician relationship just because they didn't check it. Or in the middle of the plan, that physician parts company with the insurance company. That's one. The other, and this is really pretty rare, is the seniors who are incredibly healthy, who aren't going to use a lot of that deductible or whatever, and for whatever reason they're in a market where they're paying a premium for that coverage. Now, the problem with that is, first of all, it doesn't happen very much. Second of all, it's a little bit like trying to predict if it's a smart thing for you to have auto insurance or not. Right. I don't know if I'm going to get in an accident.
Yeah.
If I get through the whole year and I've never used it, then maybe it wasn't a smart thing. But then the same thing happens with these Medicare Advantage plans. If you say, well, I'm healthy today, I probably don't want to buy one. And then you develop, a disease state or have a heart attack or whatever. Well, now it's too late.
Yeah.
That's the nature of insurance.
Yep.
But in general, I really don't think there's many people that I would advise not to buy into the Medicare Advantage plans because they're incredibly cheap.
Yeah.
For what you get.
Let's talk about what it is that you get, because there's a lot of these plans, they come with a lot of extra benefits like vision, some vision coverage or dental coverage. And most notably, what I've been seeing a lot lately are promotional partnerships for some of these plans. I know here in Michigan, Kroger started working with Grand Rapids-based Priority Health by allowing Priority Health Medicare Advantage members to get an allowance to use at Kroger. In this past week, the superstore chain Meijer announced that it is working with Blue Cross Blue Shield of Michigan and offering a similar relationship. And the one that I thought was a little odd, Ron, but I suppose there must be a market for it, is the grocery delivery company Instacart and Alignment, which is the Medicare Advantage plan, are going to be working together and providing allowances to seniors on Instacart grocery delivery. So, what's the reciprocal benefit, I guess, from each of these retailers as well as the insurance company to decide that we're going to go into this partnership? What's the benefit there for those retail entities first?
Yeah. Well, what everybody's figured out with this marketplace, with the Medicare Advantage or the seniors in their Medicare Advantage plans, is that two things happen. One, you get very targeted marketing. One of the problems with any kind of marketing is I want to get to the people who are likely to buy my product, which is why you see, and I'll use sort of the gross example. I mean, you see more, beer ads at the Super Bowl than you do other things.
Right.
Well, who's watching the Super Bowl? Guys who drink beer.
Yep.
And so you look for target marketing, and what you look for is customer loyalty. Okay, so what they've figured out is, in general, the seniors, for a lot of things that they purchase, are incredibly loyal. Okay, meaning that if they start shopping at Meijer's, they're liable to continue to shop there every week.
Yep. They're
not like, let's say, people who are, I'm going to go by whatever grocery store is on my way home, and if I'm coming from different meetings, that could be a different. I'm not that loyal. Okay, so that you've got a population that is very loyal. You've got a population, since you know a lot about them, their age, etc. You know the things they like to buy. Okay, you don't see a vaping company try to partner with a Medicare,
right.
because it's not their market. And they're incredibly loyal. So these companies, whether it's Instacart or Meijer and these others, say, hey, I want to get access to that market. You know who they are. You can get them information. You know their names, their addresses. They're used to getting information from you. So I'll do this special partnership with you. It benefits Blue Cross or Alignment or whoever the carrier is, because look at the extra benefits I'm bringing you. Just for being a member. You get this. And so that's really the design around it. Again, for the consumer, it's a good thing because they're not paying for these allowances.
Yeah.
They don't have to use them. And it's good for the retailer who could get access to what could be very loyal, dedicated customers.
I do think, though, that as Gen Z becomes in the Medicare age, that's when you'll start seeing the Juul, Centene partnership there. But that's a little ways down the road, assuming Juul is still around and not put out to pasture by some of these lawsuits. But that's not the topic of today's discussion. So thinking about some of these partnerships, because these I find interesting, because you're right that you're targeting people that are already loyal to a particular store. Are there disadvantages to the Medicare Advantage plans for this? Because on the one hand, it sounds like kind of an expensive thing to be offering every senior $500 a year, $500,000 a year to use at a particular pharmacy or a particular grocery store.
Well, first of all, it's typically not like if they say, hey, you get a $500 card at Meijer every year, whatever the promotion is. Well, the insurance company's not paying $500. Meijer is eating some, if not all of that. Okay. So, and that's where sort of this benefit becomes, because it's a little bit like why the grocery store chains will have these promotional things for certain items where they actually sell it at no profit or below cost.
Yeah.
Where they're like, oh, come in. My favorite one is, come in and spend more than X amount of dollars. We'll give you a turkey for free.
Yeah.
Around Thanksgiving. Well, what they know is people don't come in and just buy the turkey. They're going to buy everything else, and they know what the profit margin is there. So, a company like Meijer or Instacart or whatever knows that if I can get them in the first time and I can get them to spend, and it'll take them multiple trips to spend, let's say $500, they're going to keep coming. I'm going to make money on those other purchases. So a lot of those things, the retailer may be eating the entire cost as a promotional expense.
Okay. I want to transition now to talking about the provider side of Medicare Advantage. I know we can get into the negotiation thing in a little bit, but I want to start with a story coming out of San Diego. Scripps Health, which is based there, told Becker's hospital CFO report last week that they are going non-par for a number of Medicare Advantage plans, including Anthem Blue Cross, Blue Shield of California, Centene, United, and then some other ones that are regional there. And part of their issue with it is the health system says they're facing a loss of $75 million this year for Medicare Advantage contracts. How is it that for some of these contracts they could face that much of a loss at a hospital?
Yeah, there's several things that are going on when you think about the provider end with these Medicare plans. Okay, first of all, Medicare in a straight fee-for-service environment is low pay, and by itself is below cost for most providers, whether it be hospital or physicians. Okay, so that you start from that perspective. What's happening with scripts, for example, and happens a lot in California and in other states, is these Medicare Advantage plans have said, hey, we want you to take risk. So if we're getting, and these are not the right numbers, if we're getting $100 to care for Mr. Smith here, we're going to give you $80 of it, and you are at risk for all that cost. And if he chews up $200 worth of expenses, that's on you. Okay, it's a risk transfer, a capitated agreement. And there's a lot of that going out there. And those you can get underwater on fairly quickly. One of the things that happened during COVID is all of the actuarial tables got screwed up because they were based on predictions of what expenses were going to be. So the first part of COVID, we had, these massive expense increases because of COVID. And we also had certain things that didn't happen because people weren't getting a lot of their, preventative care stuff done. So now we're coming out of COVID and people are wondering what long COVID is going to look like. They also have to sort of adjust the actuarial tables for, the people have died from COVID and that were typically people with fairly high comorbidities. Well, what does that look like? I mean, and I don't mean to be morbid here. We've talked about this in other shows, but overall, the general risk profile of people over the age of 65 in this country now is better than it was pre-COVID. That's because about 750,000 people over the age of 65 died from COVID, and the majority of them had some other comorbidity. So we don't know what's going to happen for the people who didn't get their, certain preventative services done and now might have more expense. Anyways, these capitated agreements can get upside down in a hurry, and that's what Scripps was talking about. The other thing that both hospitals and physicians are talking about, which is why they're starting to get out of these plans, is while Medicare didn't pay well, straight Medicare, it was easy. Okay, you always knew what was going to get paid. They paid the claim, quickly, so it was at least simple. Well, you get into these Medicare Advantage plans, they now start to have other things that they do. Prior authorizations, pre-certs, denials, slow pay, and so those all add expenses to hospitals and physicians. And right now, some hospitals are saying, I'm done. I can't do this anymore. It adds expense to what is already low reimbursement, or I'm taking on risk I shouldn't. And the only way to get out of this is to cut it, which the problem is that leaves all these seniors without a place to get their care.
Right. So for, say for some of these seniors that are on, a Medicare Advantage plan, or particularly a PPO plan, because there are some of those out there, could they use out-of-network benefits at a place like Scripps?
They may be able to. And a lot of it depends on their individual plan. And so they always sort of go back to, you got to, look at your card, look at your plan, talk to your rep. They may be able to, but in some respects, that then eliminates the value of the plan, because the plan was really to cover those things that weren't covered. And you're back into, you're going to have to pay your coinsurance, you're going to have to pay your deductible, all that stuff. And so at that point, you should go back to the red, white, and blue card, which is, to be honest with you, what a lot of these hospitals are hoping happens is that these people will go, fine, I'll go back to my red, white, and blue card. The hospital won't take risk. They won't have to jump through all the hoops, and they'll go back to the good old days of straight Medicare.
Are these risk-based agreements, how popular are they? Are they only really in certain states, certain regions? Are they gaining in popularity? How much are we seeing of these now?
So they are definitely much more prevalent in California than anywhere else. California's been doing this kind of stuff for a long time. They're in most of the rest of the country to some degree. Now, some of them, let's say, will be, rather than a whole delivery system, might be a light sort of gain sharing and risk agreement with a large primary care group or primary care network. But some form of this is pretty prevalent through most of the country. Not nearly as advanced as it is in California.
Okay. Let's talk about, individual providers and specialists real quick before we wrap up today. I know I've seen, and I'm sure you've seen as well, Ron, sometimes the payers try to force things like 80% of Medicare for Medicare Advantage plans. What do providers need to be on the lookout for when contracting some of these Medicare Advantage plans?
Well, you need to be on the lookout on a few things. First of all, you need to be checking, what is the reimbursement level? Is it going to be 100% of Medicare for everything? Or are there some things that they're going to pay less than Medicare? Some physicians believe that it's illegal for them to pay less than Medicare. That's not true. If you sign a contract that says you're willing to take less than Medicare for a Medicare patient, then that's what you're going to get paid. You're going to want to look at, are there provisions in the contract in the Medicare contract that you really don't want them to do? Some of the contracts out there ask for direct connection to your EMR. And the reason for that is they want to try to make sure they're capturing all the diagnoses because they can increase their risk score and get more money from the federal government. Well, do you want an insurance company mucking around inside your EMR? You got to look for things like that.
Right.
There are other provisions as well. You need to understand, how much extra administrative cost is this going to be? Are you going to have to do pre-certs that you didn't have to do? Are you going to have to do, switching of drugs for certain things because they want you to fail this drug first before you use the drug you want to use? All of those things need to factor into the decision of, can I take care of these patients without it being a financial hit to my practice? I was on a call earlier with somebody from the insurance companies, and they were saying, well, geez, if you don't do this with Medicare patients, why did you become a doctor? And my response was, well, I understand that, but these doctors don't get federal subsidies. It's a business like any other business that has to survive financially. And the analogy that I used was, I said, look, ask any senior to walk into the Apple store and try to buy a MacBook for 40% less than what the sticker price is, and they're not walking out with a computer.
Yeah.
But that's in essence, to a large degree, what happens with Medicare. They walk into a doctor's office, they buy their product, an appointment, and they pay anywhere from 50 to much more than that % less for that product. And we sort of think that, well, you should have to do this because you're a doctor, but no one else does that. There's no other business that would do that. So it's the provider should think about this very, very carefully, because I know they want to care for these people. They need care, but you can care for people until you're, out of business.
And finally, if an insurance company tells a provider that they cannot terminate their Medicare Advantage without terminating the entire contract, is that true or false?
It depends on the contract.
Okay.
In some cases, it is very true. So some contracts that providers sign that will have a master contract or the base contract, and then it will have product attachments. There may have a PPO attachment, an HMO attachment, a Medicaid attachment, a Medicare attachment. And depending on the language of that contract, in some cases you can terminate just one of the attachments. In other cases you can't. You've got to terminate the whole contract to try to get out of Medicare or Medicaid. Now, what's really bad is some of those contracts allow the payer to terminate one of the attachments, but not the provider. So they could be a one-sided termination of an amendment or an appendix. And so it really, behooves you to sort of take a serious look at it, because you could find yourself saying, I don't want to do this Medicare stuff anymore. And the carrier saying, well, then you're going to get rid of everything else as well.
Right. Ron, we're just about out of time. Thanks for sitting down with me today to talk about Medicare Advantage.
No problem. Happy to do it.
Miss an episode of the Flatlining podcast? Well, now you can read a recap. Just go to flatlining.net and look right there on the homepage every Monday for a written recap on last week's episode.